about a very interesting theme today, and we are starting the journal club, which will be on a monthly basis to cover the key aspects of pediatric endocrinology, especially the research part. So as part of the first session, we'll be focusing about 4 articles. 3 of these are about new therapeutic options, which are available in different scenarios. And 1 is about the diagnostic issues. So we'll try to critically analyze as to what really is being published in the journals is one part, and whether it will change our practice or whether it should change our practice now or in future will be the key themes which we'll try to focus on. So whenever we do a literature analysis, basically we have to look at a scenario as to whether we need to change our practice or not, because that's the most important part, and this is what we'll be focusing about. We have to look at the validity of a particular study, whether it's valid or not, whether that particular study is generalizable or not. So the main aim basically is to see whether we can change our practice based upon a study. So that will depend upon whether the study is valid or not, whether we can generalize that study or not, whether it is a novel work or not. So we see that there are so many papers which are published every time so much research happens. Only a small percentage of them actually change the actual practice. So we have started off with this grand round. You all can go and have a look at our website, learning.growsociety.in, which covers a lot of pediatric endocrine resources, including programs, training programs of fellowship and diploma, which are available. We do a lot of our webinars, including the grand rounds, postgraduate lecture series, and now the journal club, which is there. There are publications which you can access, and this is the mobile application which can be accessed. Dhwani, who will talk about the effect of long-term PTH replacement therapy in hypoparathyroidism.
Parathyroid hormone replacement therapy in children with hypoparathyroidism. This is a study from, so why was this study done? Hypoparathyroidism remains among the few classic hormonal insufficiencies where replacement therapy remains widely unavailable. These children require multiple high doses of calcium and calcitriol, which predispose to nephrocalcinosis. And to avoid hypercalciuria-induced renal damage, the dose of calcitriol must be adjusted to maintain serum calcium at just the lowest tolerated level. Also, inadequate control is achieved in those with genetic etiologies like APS1, where patients have intermittent malabsorption, or in those with calcium receptor mutation, where high urinary calcium losses are present despite low serum calcium. So how was this study done? This was an observational study done at NIH Clinical Center, Bethesda, Maryland. It included all children with hypoparathyroidism due to APS or calcium sensing receptor defect who were genetically confirmed. So the study subjects, the final cohort was about 14 children. At the onset of study, these children were admitted for a period of 1 week where baseline evaluation was done. This conventional therapy that the children were originally on was discontinued, and they were started on twice daily PTH injection subcutaneously. The study cohort was followed up 6 monthly, and at follow-up, again, there was review of interim history, physical examination, and the baseline study was repeated. As a part of baseline evaluation, height was measured as a mean of 3 readings by Harpenden stadiometer. Bone density was measured with DEXA, and bone density was measured annually. 3 days baseline and follow-up, that is 3 days initially at the first IPD visit, and subsequently at follow-up with pre-PTH injection, serum values of calcium, magnesium, and phosphate, and 24-hour urine estimation of the same electrolytes was done. Additionally, bone turnover markers, ALP, urine pyridinoline, and deoxypyridinoline was done. And at the onset of study, renal CT and ultrasound grading, renal CT and ultrasound were done for grading of nephrocalcinosis, which were graded from 0 to 3, where 0 was no nephrocalcinosis and 1, 2, 3 were mild, moderate, and severe nephrocalcinosis. Injection parathyroid hormone was initiated at 0.5 mics per kg per day in 2 divided doses. During this therapy, magnesium supplements were continued. However, calcium and calcitriol was stopped for all except 1 child who also had malabsorption and required oral calcium supplementation. Injection sites included arm, thigh, and abdomen, and the patients were advised to rotate sites. As for the analysis, sex and pubertal status specific bone mineral content and aerial bone mineral density velocity Z scores adjusted for baseline age, height, weight, and similarly for interval weight and height were generated from the BMDCS, and predictions were based upon generalized mixed effect models. Longitudinal trajectories for each outcome measures were estimated using linear mixed model approach. The time of study was divided as first year of treatment and 1 to 10 years of treatment. And then the urine creatinine clearance was adjusted for.
So before you go into what they found, what will be your, what will make you happy as a patient with hypoparathyroidism? Suppose somebody says a new treatment has come up, what will be most important for you?
So as we know that they've included APS1 and calcium sensing receptor, in these children, it is very difficult to maintain a normal serum calcium levels. And we know that despite multiple doses and with transient illness, their requirement will shoot up. So I would want their serum calcium level to
go in.
Yes, a stability in serum calcium.
The complication to be less. That's a normal scenario. Anybody would like the levels to be controlled. So when you say diabetes, you want the HbA1c normal and no complications.
Yes.
So here the levels will be calcium.
And urine excretion.
Second would be with regards to the urinary hypercalciuria.
Yes.
Now the other issue, of course, here in this scenario is what about the medication? Do you think medications also is an issue?
I'm sorry, I don't understand.
So how many medications the patient has to take?
Yes.
I think that could also be an issue.
Yes.
So if you can cut down on the number of, because sometimes they tend to need up to 10 tablets of calcium or 12 tablets. So that becomes a bit of a problem. So if you can simplify the regimen and if you are able to get more children in the normal range without causing hypercalciuria and nephrocalcinosis is what basically we are looking at in that regard. So now what they found? So
what they found was the mean PTH dose was 0.35 plus minus 0.08.
So how did they titrate that?
It was they were following up monthly, and based on that the doses were titrated. The mean dose did not differ based on the diagnostic group, and individual PTH requirement was mainly influenced by the severity of illness. The mean treatment duration was 6.9 plus minus 3 years. So it was a significantly long follow-up study. Looking at the baseline characteristics, the children were mainly from 7 to 16 years of age. There were 5 patients with APS and 9 with calcium sensing receptor defect. And in the APS1 arm, the age range was 7 to 12, and in the calcium sensing receptor 7 to 16. So that was the thing. All the patients at the start of this study were on calcitriol with calcium, except patient I, who was an alpha calcidiol.
Which doesn't.
And
So what is the management difference between calcium sensing receptor defect and APS1?
Management difference.
Yeah. So what is your target calcium level, or what is the risk you're looking at?
In calcium sensing receptor, we tolerate a lower.
You want a lower level because if we develop hypercalcemia, even if the calcium becomes normal. So the risk of hypercalcemia, hypercalciuria is maximum for the calcium sensing receptor.
Yes.
So they will be the most likely to benefit from a therapy which prevents hypercalciuria. Yes. Now, the reason why PTH treatment will reduce hypercalciuria is the PTH direct effect on the urinary calcium reabsorption. Now, APS1, again, the issue is that there is huge variability because of the absorption issue. Sometimes they will need less, sometimes they will need more. So this is more for stability purposes.
Yes.
So they have not included any other congenital forms of hypoparathyroidism, no Digeorge syndrome, no HDR, so no syndromic causes have not been included. Because of this, they want 2 groups which are most likely to benefit.
Yes.
So when you are using an intervention, choose those who are most likely to benefit. Suppose you are treating growth hormone treatment, you will use the most severely affected rather than the mild affected. So here you are using calcium sensing receptor defect because there you can see the difference in hypercalciuria. You're using APS1 because there are a lot of fluctuations and now the levels will be normal.
And the urine RFTs were normal at baseline in all the subjects, and nephrocalcinosis was present in all subjects at start of study.
So this is a big message that everybody, even at a younger age of 6 years, 5 years, 7 years, they already had nephrocalcinosis, which means that this is a very inevitable problem which will happen in hypoparathyroidism, that they will develop nephrocalcinosis.
So this is the linear growth in bone mineral accrual velocity. So it was found that the height velocities were normal for age in all the study subjects. Even the bone mineral density seen for the whole body, lumbar spine, total hip and femoral neck was pretty much in the normal range. Only the radius, distal 1/3 of radius bone mineral density was slightly in the lower range, which subsequently improved in the 3 to 5 years of therapy.
So why do you think hypoparathyroidism will have a low bone mineral density?
Hypoparathyroidism is a state of like hypocalcemia. So
if you correct your calcium, do you think you will still have low bone mineral density?
yes.
So theoretically, PTH may have an impact in terms of bone formation. So that's what they're trying to look at it. But what you are seeing is that it doesn't have a huge difference. So even with hypoparathyroidism, if your calcium is all right, you don't have a low bone mineral density, except for the radius bone. So what type of bone is there in the radius region, Manoj?
Like continuously growing.
Which type of bone? Trabecular. Trabecular bone, you will see more rapid changes.
Yes.
Trabecular bone is more metabolically active. So there you will have an impact quicker. But overall, somebody like they had a disease long enough to cause nephrocalcinosis. This was not long enough to cause osteoporosis from that perspective. So which means that you don't need to bother much about bone mass in hypoparathyroidism.
Yes.
What about hyperpara?
Hyperpara will also have a very high bone turnover and
bone mass will be
less.
So if you're giving PTH in an overdose, you may actually cause loss of bone. So they are looking at both perspectives, whether the bone is being lost also, because you may be giving supraphysiological PTH. So that does not also happen. So from both angles, this becomes relevant.
So looking at the bone turnover markers, again, as we can see, the mean calcium level was within the normal range. It was lower for calcium sensing receptor and mean phosphorus. So
that would probably be on purpose, that they are keeping the calcium sensing receptor on a lower level of calcium.
Yes.
This is what they are trying to achieve on that. Now, key parameter is urinary calcium. Now, this is interesting. What you are saying is that despite having a lower calcium, the calcium sensing receptor defect individuals have a higher urinary calcium. They have, for the same level, they have more hypercalciuria. The other parameters are, I'm not too much concerned about that. Mainly, I'm looking at urinary calcium, which is higher, and serum calcium, which is lower, in the setting of individuals who have basically the calcium sensing receptor defect.
Looking at the impact on serum calcium at the onset of study, looking at the baseline parameters, which were almost comparable for APS1 and calcium sensing receptor, there were some about 10% of children in the high category, maximum in the normal, and about 20% to 20% of the APS1 and 40% of calcium sensing receptor in the lower side.
Do you think there is an error in the way they have decided the cutoff? They use the same cutoff for both groups.
Yes.
Which is not appropriate, probably, especially when you are treating with calcitriol. If you're treating with calcitriol, you want them to be on the lower side. So in that regard, what they are saying that 40%, which means total of how many in the CAR group?
9.
So around 4 patients in the CAR group were having hypocalcemia, and around 1 patient probably in the other group had hypocalcemia. What happened with treatment?
So with treatment, it was found that although the number of high reduced, but the number of normal, the high and normal, both of them came down, and the number of patients in the low group increased.
So what you're trying to say is that with PTH, your actually hypocalcemia was higher.
Yes,
so it is something like that. You've got a newer insulin with which your HbA1c is becoming worse. So if your primary outcome measure is calcium control, and you say, okay, I want to improve calcium control, probably this is not the answer. At least here it is not showing that it is going to improve, because you are basically becoming hypocalcemic, which may not be good also in that scenario. So this is something which raises the first question. See, whenever we talk about a new treatment, like you're talking about PTH and hypoparathyroidism, we talk about liraglutide, or we talk about CRH antagonist, there is an inertia of an existing treatment. This treatment has been given for ages. Now, if you want to change that, you need to have a significant push. So the new treatment has to be very beneficial for people to change their diet.
Yes.
So if you are saying actually the calcium will go down, I will be very uncomfortable with that. Next. Yeah.
Looking at the impact on urine calcium excretion, it was at baseline, it was predominantly in the high range, most of our patients in the high range, and with the intervention, there was a significant improvement seen in urine calcium excretion, with about improvement in 2 patients per diagnostic group.
This is showing is that from the hypercalciuric range, the number of patients shifted to the normal range.
Yes.
But what you are basically doing is that you have shifted the calcium to the left.
Yes.
Your calcium has come down. So if your calcium comes down, hypercalciuria will come down. I would be happy if your calcium remained normal at least. It did not come down and your hypercalciuria came down. And despite that, what we are seeing around 40% those with the AR defect and 20% in the other categories still had hypercalcium.
Yes.
So this is not a very impressive result. So if you had down titrated your results with calcium and calcitriol, you would have achieved the same finding.
Yes.
So you're shifting your calcium curve to the left at the cost of causing hypocalcemia. Still, the benefit of hypercalciuria is not remarkable. So this again for a new therapy is disappointing.
Looking at the calcium phosphorus product, the mean was 41 plus minus 8, and the target is usually at less than 55 to prevent risk of renal calcification. And it also did not, the product also did not correlate with 24-hour calcium excretion in this study.
So this basically says that there is a less risk of hypercalciuria.
Yes.
So it is something like that. You can say, okay, I'm maintaining the sugars at the higher side so that hypoglycemia is there. So it is something like that.
Calcium phosphorus, that this is what deposited in the bone or what?
No.
Is most important. So ultimately, there will be the kidney will be the most important part. So what basically, as I said, the analogy is that you're giving a new insulin preparation, which is causing less hypoglycemia, but the sugars are high. You're shifting the curve to the right, so your hypoglycemia is less. You are making them hypocalcemic, and then they have hypocalciuria. So that is not an ideal way of going forward.
So in the renal results, the creatinine clearance remained pretty much in the normal range. There was no change on the renal functions. Nephrocalcinosis was present in all at baseline, although not as a part of study. 12 out of 14 patients underwent repeat renal scans for nephrocalcinosis, of which 5 showed progression.
So this is again
with no
a big
change
message. We don't have a control arm.
Yes.
So we don't know the control arm, what is the natural course of nephrocalcinosis, whether it worsens or doesn't worsen, or it's already so bad it can't worsen. Suppose somebody his retina is completely damaged and you say it is not progressing, he's already at 0.
Yes.
So we don't know the severity. So they are saying is that 5 still progress, which is a concern for me. So what you are saying that new therapy, still you have a progression as far as the nephrocalcinosis is concerned. Now, we don't know whether it is too early for the renal dysfunction to set in.
Yes.
So without a control arm, we can't really say much on that.
And no study-related serious adverse events were noticed during the study period. One of the patients developed tibial bone pain, for which the dose was changed from twice to thrice. And children with APS1 continued to have on and off complications because of the inherent disease itself. So in the conclusion of study, PTH given twice or thrice daily subcutaneous injection was found to be safe with a normal linear growth, bone accrual and kidney function, and normal or slightly below normal serum calcium values in nearly all measurements. Nephrocalcinosis was present at baseline. I have already highlighted this part. And it progressed in 5 out of 12 who underwent repeat renal imaging, which highlights the difficulty in normalizing calcium homeostasis with twice or thrice daily injection. Although PTH during the study were consistent with prior studies, which have shown treatment of genetic hypothyroidism requires higher dose, whether administered twice or by pump, compared with treatment of post-surgical hypoparathyroidism, and no long-term adverse effects were noticed. So, although, so looking at the positive part, this was definitely a long, sufficiently long period of follow-up was done for these patients to know whether PTH therapy worked or not really. But the parts where it lacks is this was an observational study with a very small sample size and a very small subgroup of hypoparathyroid patients recruited here. What can help here, what can help better is an RCT comparing the original therapy that we're already giving, calcitriol plus calcium, versus an injectable parathyroid hormone therapy, and a longer follow-up. And the values were again in mean, which may not be most valid for small sample sizes, and a median would have probably given better idea. Multiple PTH injections are pharmacologic replacement, but not physiologic. So in short-term studies, continuous delivery by insulin, continuous delivery like by an insulin pump have shown to produce more physiologic calcium profiles and reduce the need for magnesium supplementation and overall PTH dose requirement. To address the problem of intermittent hypo or hypercalcemia, self-measuring blood calcium device is an urgent unmet need. It could permit frequent dose adjustment, reduce overtreatment, and reduce IV calcium administration during emergency visits for tetany and seizure.
It's like a glucometer, you have a
Yes,
calciometer, which is measuring the calcium levels, and you're titrating based upon that. So basically what this tells us is the limitation. So theoretically, it is very good that if you're using PTH in replacement of the calcium and calcitriol, in that scenario, you have got a good benefit which is happening. But the limitation is in terms of practical issues. So when you talk about PTH giving twice a day and body is producing PTH every 5 minutes, 10 minutes, as per the calcium, it is not going to do much. So it has to be either like a closed loop system sort of a thing for artificial pancreas, the artificial parathyroid. That's what you're trying to create would be the ideal way. Till that time, probably it is. So if you have now a patient who comes to you, he has read this study, they want to say, okay, my child, shall we go to PTH? What will be your recommendation?
Maybe not right now. We need better evidence with like an RCT kind of study to actually prove that this therapy is better. Because this, as of now, this therapy has not shown significant benefits. It is an injectable therapy. The cost of therapy will be high. So if all of this goes against recommendations.
So for exceptional cases where you have significant hypercalciuria who are not getting controlled, maybe CAR defect, those will be those very rare scenarios where you will think about it. But otherwise, till now, there is no role of routine use of PTH in childhood hypoparathyroidism. But the other big issue that this is PTH 1 to 34. What about teriparatide? People have studied teriparatide in children.
Teriparatide also, maximum studies that are available are in adults. Very few studies in children. Again, observational studies, including 4 subjects, 5 subjects. So
case report based studies.
Yes.
So whether we can translate the results of the intact PTH to teriparatide is also a question. And intact PTH is also not readily available. So basically, just to give a final word on that, probably at the moment, we are trying to use a NPH like insulin to cover the entire process, which is not going to happen. You would need to have a sort of, as you said, closed loop, sort of artificial parathyroid. That will be the best. Otherwise, in something such a dynamic situation, you will have high, low, all those fluctuations will happen. All of you can go and have a look at our website, the courses and the mobile application.